Sorry for the delay. So yeah, miscommunication, and the Lyft driver was, I guess he just started driving Lyft today, and it was a total mess. Anyway, I ended up getting a free ride, I think.
So yeah, that'll advance.
Yeah. So my name's Aldo Maspons. I'm a pediatric gastroenterologist, and a year ago I became an entrepreneur. So we're gonna give a little bit of talk about tech, and then this is super informal. So if there's questions that you have, or questions or doubts or whatever concerns, just please let me know. Try this. Shoot this way. All right, so financial disclosure. So I'm the CEO of this company, VemiDoc, and I also give a couple of talks here. So I'm going to give a brief overview of this new tech, and I'm also giving a little bit of insight that about the startup culture and how it's feasible, and it's actually going on now already in your world, transplant world, and with people that you know. So my story starts off here. This is Santa Clara University in the Bay Area, so Silicon Valley, and I started school in 97 to 01 is when I was in college there, and that was the beginning of the .com boom, and this whole startup culture was relatively new. People were getting paid, I guess in the beginning, millions of dollars just for PowerPoint presentations, so that's why I'm here today. No, I'm just kidding, that was a joke. But that's how things were getting funded, and so it was really a really crazy time to be in the Bay Area, and I was not really focused about this whole tech thing because I'm from El Paso, Texas, and we don't really have that much tech at the time. Internet was brand new to me, and when I started school, I saw the internet was in color, and I was like, wow, this is amazing. So from Santa Clara, I went down to UT Southwestern, and that's where I went to med school. And it was really research heavy. And so I found out that Southwestern had two favorite sons. One of them was Michael Brown, who's the LDL guy. And when I was there, I just kind of realized, I'm not sure if this is my thing, this whole research heavy thing. And then we saw the other favorite son of UT Southwestern, is Dr. Figueroa. And so, wow, there he is. I realized that I can go anywhere and just say, hey, Dr. Figueroa, and people just get happy. It's a weird thing, especially here in San Antonio. So it's. But my life really changed when I was on call. So I did a fellowship at Texas Children's at Baylor College of Medicine, and Dr. Vardabedian is the one who really changed my life. So I was on call with him, and we were at Chipotle in line, and I was kind of confessing, like, I'm not really sure I'm a tip, like I have this research thing, it's just not my thing, and so he was telling me about his life, or what he kind of started doing, and so fellowship was 06 to 09, so this is probably like 07, and he's a big blogger, so I don't know if you read Kevin MD or that kind of medical blog, so he's like at the same time started off the medical blogging, and he was telling about the story where he was blogging about what medicine is, and Texas Children's kind of called him into the office and said, hey, we know what you're doing, and he's like, what am I doing? Well, you're blogging. He's like, yeah, and this is the time to start blogging more, actually, and so he kind of brought the comfort level more for everybody involved, and talked about how it's important that we as physicians and we as medical professionals get at the forefront of this medical information, because patients are out there doing it themselves. So there's Dr. Google, and there's also well, that's not really Dr. Google, right? All the patients Google their ailments, but also there's a lot of support groups that are formed where patients are kind of treating themselves. And so if we can get out in front of this and lead that conversation, then I think medical outcomes will be a lot better. But also we can give some guidance to our patients. And also there's kind of fringe talk. So this is kind of the first time where I heard that the fringe end of things where patients are requesting or want to move towards a society where they themselves are diagnosing themselves and treating themselves. And so that's kind of where people want to be. And as a medical group, as a responsible medical group, we should kind of guide the ship and to say, well, this is maybe in not so patriarchal terms. This is where things should be, where it's safe. So Moneyball was something, I don't know if you heard of Moneyball. There's a movie that came out, but there's also a book. And this is something else that kind of really inspired me. So this is in 2002, and the New York Yankees had a payroll. I'm not a baseball guy, but I'm an Oakland A's fan because I used to live in Oakland as a kid. Oh, okay, perfect. So I lived in Oakland as a kid, so I cheered for Oakland, and this was their payroll here, $39 million versus $114 million for the New York Yankees. And that year they didn't win the World Series, but I think they clinched their division. And they did it just using statistics and analytically evaluating players to say, oh, this player is due for a home run, or he hits a home run every so often, and this player, he's really good at X. And so they brought together all these analytics, and with that, they were able to field the lowest payroll team and advance well into baseball's fall season. And this is something that's been passed down not only from baseball, but now to basketball, the Houston Rockets, and also now Golden State Warriors. And Golden State Warriors are actually a startup team, so to speak. And it's also being taken over into medicine. So this is Improve Care Now. I don't know if anyone's heard of Improve Care Now. It's an inflammatory bowel disease quality improvement program. And what they did was they in inflammatory bowel disease, the best medicines, the most expensive medicines, are only 30% better than placebo. And so it's not too great, but if you look at these kind of the three things that they evaluate, the first one is percent of patients in remission. So the green line is pretty close to 85%, or the green line is about 83%. And you see that there's a constant march. When the program first was started, this is from Cincinnati Children's, and it started kind of taking off in 2007. And so as more and more people get involved with this program, the march towards remission increases as a whole. The second graph is the percent of patients in sustained remission, and you can see that it's close to 50%. So again, better than placebo, 30%. And then the last graph is percent of patients with prednisone-free remission, and that's the green line is 75%. So you can see everyone's above 75%. And so what this program is, it's a quality improvement program that looks to standardize care for inflammatory bowel disease, so that patients, when they are having an exacerbation of symptoms, that they should be on certain doses of medicines. And what they found was there was a lot of variation in the way physicians were prescribing mesalamine or other medicines, and they were using steroids often. And so what they did was just kind of standardize the care. And now anyone can go to improvecarenow.org and look what the standards are and apply this to their patients. So bringing all this together, I put together my research project, and this is my mentor here, Dr. Rob Schulman, who's big in the abdominal pain world, irritable bowel syndrome world. And we figured, could we do kind of Moneyball techniques for hospitalized patients, trying to anticipate which kind of patient with inflammatory bowel disease will be hospitalized. And there was kind of non-traditional markers that we found, and one of them was phone calls. So we found that as the number of phone calls increased, that those patients can get flagged and say, okay, this patient has a higher risk of being hospitalized. But then the problem was that there was not a lot of appointments. So even though they had problems and they had symptoms, they couldn't get in to be seen because everybody was booked. And so they had to get taken to the emergency department, which maybe could have been handled as an outpatient, increase the cost. So phone calls was one. Tracking their weight was another. So we saw that patients who lost weight had a higher risk of being hospitalized. Medication adherence was another big one that we looked at. And patients who skipped their pickup times from their pharmacy were also more likely to be hospitalized. And so we put this as a risk stratification, and we're able to kind of flag all these patients to say, okay, these patients are the ones we need to focus on to prevent them from being hospitalized. So a little bit of Moneyball techniques, at least is what I was trying to do. And what I realized that there was actually people doing this already. So real-time health predictive analysis, which essentially is a quality improvement. So these are taking certain patient characteristics, behavioral biomarkers, if you will, and putting them into a model. And there's a lot of artificial intelligence now and machine learning now going into these kind of formulaic or programming measures to prevent whatever it is that the question is trying to answer. And we'll talk a little bit about machine learning. So this is a diagram of the course of medicine from bench to an actual production of medicine, and the average time takes about 12 years, and 1 in 5,000 trials actually become a medicine, and the average price is about $359 million. And so it's impressive to think that, and this is kind of the reason why I don't want to go into research, because this seems really intense. 12 years, and you might not even get your medicine out there. And so is there a cheaper way? Is there a faster way? Is there a more efficient way to affect healthcare and affect medicine without having to be in the lab, without having to spend $359 million to do it? And so that's kind of why I went through this whole process before, right? Showing the improved care now, showing the quality improvement, the whole Moneyball technique, that there are ways to kind of affect healthcare without having to spend a lot of money. This is a representation of the GDP. And so the Department of Health and Human Services receives $1.01 trillion. This is, I think, this year that came out. So it represents about 26% of GDP. So there's a lot of money in healthcare, and a lot of people are realizing this, and there's a lot of ways to improve healthcare. And when you get things like Pharma Bro, does everybody know who Pharma Bro is? It's the HIV medicine, Sakali. He's more famous, so I'm a big rap music fan, and he's more famous for buying the Wu-Tang album. If anybody knows what that is. So Pharma Bro, hepatitis C. So there's a lot of expensive medicines, $100,000 medicines, personalized medicines, gene therapy. Everything's really, really expensive, but there's other ways to kind of get involved in medicine to improve healthcare. And I was at a conference, and so I got this. I started thinking about more kind of tech's involvement in healthcare, and I went to a big conference in Washington D.C. and all these major players were there: Google, IBM, Apple, HP, Verizon, AT&T was there, a bunch of others, non-medical. Traditionally, at the time, this is about 7 years ago, and there was a room, probably like 1,000 people in the room, and they were talking about how they were going to revolutionize healthcare, and everybody was getting really excited. It was almost like I was at a congregation or something. Yeah, everyone was cheering. Yes, we're going to revolutionize healthcare. Yes, and they're like, how many physicians are there? I was the only physician in the room, which was scary to me that there was a group of people talking about revolutionizing healthcare without a single medical person in the room. And it was scary to think 7 years ago, but now it's not hard to imagine, because the people disrupting the auto industry are not automobile makers, they're software people, right? So it's a computer on wheels. So Apple is rumored to be making a car. That Tesla is the biggest threat to the auto industry now. And so why is it hard to believe that these people, these organizations are going to be the next big thing in medicine? And we should be a part of that conversation. In fact, we should be the ones leading that conversation. So this field's going to get disrupted. And the major hurdle to all of this, because there's a lot of money being pumped into healthcare and a lot of people are paying attention to this, but the major hurdle is the culture of each institution. So the culture here is different from the culture in Wisconsin or transplant groups. I don't know if when you get together, people do things a little bit differently. And also there's a trust issue too. You can't just have somebody fly in. So if I came in today and said, hey, I'm a great transplant hepatologist. I'm not, but I'm just saying, if I'm telling you this, you're not gonna just trust me. I hope not. You're gonna have to work with me and see how things go, and we establish a relationship and a rapport, and you kind of see how I am. And I think that's one of the hurdles, and I think that it's a good thing, but that's one of the reasons why it's been very difficult to disrupt this industry from a tech standpoint, is because each institution, each group does have their own kind of lingo and their own culture. So when I finished fellowship in '09, so I said I'm originally from El Paso, Texas. My mom lives there. My cousins live there, and my dad still lives there. And so I took my first job there. I was driving from Houston to El Paso, and at the time there was only one pediatric gastroenterologist there. And there's 250,000 kids in El Paso, Texas, and there's one pediatric gastroenterologist, there's one pediatric pulmonologist, there's one pediatric neurologist, and pediatric surgeons, we had 2. So I thought, man, I was driving, and I was telling my wife, man, it's gonna be crazy when we get there. People are just gonna be like showing up at our door. They might find our address, and it's gonna be like all these people, and how am I gonna help all these people out? And so I was just looking at what the major cities are around El Paso, and so we have San Antonio as the closest major Texas city, so it's 8 hours away. Phoenix is 6 hours away. Albuquerque is 4 hours away, and Denver is 9 hours away. So it's tough, and there's a lot of families that leave El Paso. So there's a kid we sent over just this week for a heart condition who had to get flown out here. So what is a way? So I was thinking about different ways that I can help such a large area of patients who don't have a lot of specialists, and kind of how can I multiply myself to serve as many people as possible in an efficient way. So this is Sarina. This is my niece here, and I put a picture of her. My niece is wheelchair bound, and she has mitochondrial disease, and she has a lot of motility issues with her intestines. She has a lot of kind of like cerebral palsy, and it's difficult to so my mom and my sister are her primary caretakers, and when she goes to see her physicians, her neurologist and her oncologist, she has to sit it's tough to get her out of the house first. She has this big wheelchair, getting into the car and then taking her to her doctor's visits. She spends 2-3 hours in waiting room, and it's difficult, and the doctor we basically have to accommodate what the doctor's schedule is, and I think it's a little unfair. She just it ruins like the next day and a half. She's totally a mess, and there's a lot of patients like her in El Paso as I've been working more and more, and I see a lot of the families that they struggle with this, and so I tried to do something that can help her and patients like her see their physicians without having to just take a big chunk of their time. My sister misses a lot of work, and my mom does too. So I came up with this idea to see patients via phone, where patients can see their physicians or their health provider's schedule. So patients can see my schedule right now on their phone, and then book an appointment, and then we can connect. And that's kind of one of the things that we're working on. And so that's essentially telemedicine. And things are changing quickly in Texas. So this is in June, the law was passed, at least, that patients can see their physicians for the first time, establish a patient-physician relationship via telemedicine. And so what it did was then it just lowered the barriers significantly in the state of Texas. So now patients can see any of their providers. In fact, so my niece is now able to see her neurologist in Houston doing this. And she has a neurologist in El Paso, but he has like an appointment every 4 months or 5 months. It's pretty difficult to get in to see him. So Texas Medicaid codes are in line with this. Most of the major codes are in here. So most of the follow-up visits, 99212, 213, 214, 215. That's the old and new. And then there's the new patient codes as well. as long as there's a modifier that's used, and that modifier is 95. And this is as of June 2017. And the reimbursement, the biggest hurdle right now is reimbursement. And so there's certain criteria that have to be met in order for these visits to be reimbursed. And as you know, insurances kind of follow along with what the government says in terms of what their standard is, most Medicare. So we came up with kind of a playbook also to figure out a way. So I crossed these out because I figured this might be recorded, and I had to like protect the play. But we wanted to do something, and this is not kind of meant for you to read along because I have really bad handwriting. But mostly they were trying to do something to disrupt the healthcare industry in our own way, and knowing that there are not a lot of physicians in El Paso, knowing that there are really long wait times, knowing that there's not a lot of specialists in El Paso, what could we do to kind of facilitate, and knowing there's a high poverty level in El Paso as well. What we did was we created a medical home through a PCP's office. We're doing this project now. We're going to be doing this in other areas around the city, where the PCP can refer patients to all their specialists that the patient needs that we have in El Paso, and book appointments, and the patient just goes back to their very same medical home and gets to see their specialists. So we're doing this with nephrology, and we're doing this with colorectal surgery and general surgery, and soon with ID and cardiology. So patients only have to go to one place, and they're getting seen, and it doesn't have to inconvenience them. They live close to this clinic. And the reason why we did a clinic is that way they have an establishment with a medical professional. They get to get their vitals done, and then there can be some reimbursement involved as well. So Paso Times read an article, 2015, El Paso has the longest doctor waiting times among nation's 50 largest cities. I think it's 30 minutes, I'm not sure how long the wait times are here. It's about 30 minutes. And I read an article this week that showed that once you pass 20 minutes in a waiting room, that you get pretty upset, and it ruins the rest of the visit. So you can imagine how, luckily I have a lot of jokes for my patients, so I think I don't. So 13 doctors for every 10,000 residents is what we have in El Paso. And so I was saying for kids, we have 250,000 kids. I think we have about 50 pediatricians in the city, so it's pretty underserved. So this is the lean model. And lean model is what companies are following to build their product, get their product out, and test it. And we do this in medicine all the time. So they have an idea, they build to give that idea manifestation, code it, they measure it by looking at all the data, and they learn to say, okay, did this work or not work? And we do this right in medicine. It's a hypothesis-driven field that we have. We have a problem, we figure out a solution, we test the solution, and look at the data and draw a conclusion from that. So we're constantly doing this. So we do have a startup culture in medicine. And this is the next big thing. So what I'm going to talk about in the next few slides are, this is going to be a really quick talk, by the way. I think I'm talking too fast. What I'm going to talk about the next few slides are the next kind of technology in the pipeline. And this is one of the major ones, blockchain. Has anybody heard of blockchain before? Has anybody heard of Bitcoin? So Bitcoin is a currency that's international, has nobody owns it, right? In terms of like traditional institutions, banks, whatever. So there's no fees involved with Bitcoin. And what it is essentially, so it uses blockchain technology, and what it is a public ledger. So anybody could see it, and it timestamps transactions. And so you can go back and look to see what all that happened in that payment. Two people have to have the same address or keys kind of to match up, and you can approve the transaction, and anyone can look back and see what happened. So in order to hack this, you have to hack all of these, and it's pretty difficult to do. But there's one common thread, and so people are looking at this as a way for all the medical records to kind of come together and share blockchain, so that no matter what EMR you have, that you can use this and go back to look at things that everybody wants to know. Did this patient pick up their medicine? Did this patient get their labs drawn? So everyone will be able to take a look at this. So the pills is a big one, so medicine. So now, if you share the same EMR, you have to go back in time to go back, okay, when was this canceled? When was this not? When was this added? And there's a bunch of different EMRs, bunch of different providers that are adding medicines to this patient's regimen. It's a little bit of a task to kind of go back in time to piece it together. What blockchain would do is just give you the end result. This patient has this one medicine, and that's it. You don't need to go back and comb through all the other data. So again, it's a public ledger. MIT is using it for electronic medical records. I think it's called MedRec. And so using it to demonstrate, to build on patients' labs, patients' office visits, the medicines that were drawn. And so trying to create a common language where all different organizations from all different parts of the country can go back and look at the same data. This is just kind of a trend, so a search trend for mobile health apps. You can see that things are really taking off. This is just levels of popularity in Google, and I'm not really sure, they're not really transparent about how they measure the 100, but it's mostly like searches, and there's algorithms behind that. You can see that things are getting more popular, and we realize that. This is for telemedicine's been pretty steady. There was a big jump, and I'm not sure why it was a big jump in, was this 2014 or 2004? One of the big ones is like ECHO, the ECHO project. I don't know if you've heard of the ECHO project from hepatitis C management from UNM. And what they did was, so UNM's a rural state, and they have a lot of hepatitis C. There's a lot of heroin use in New Mexico. And there's a few, most of the specialists live in Albuquerque. And so what they did for the ECHO model was they figured out a way to manage patients with hepatitis C without having patients having to drive all the way to Albuquerque, which typically is like, depending on where you live, 4 or 5 hour drive. So they sit around a table, the gastroenterologist does, or the hepatologist, and they are presented patients from around the state. And then those providers from around the state say, hey, this patient has this, these are the labs, can you help us with this patient? So that those hepatologists help them manage those patients, and outcomes are the same as if they were in Albuquerque. So that's the ECHO model, and I think that's kind of when it started taking off. And things are kind of steady along the way. This to me is the biggest one. This is something that was published last year, or 2015, so 2 years ago. So has anybody heard about this IBM purchase of this company? So this is in business news. Most of the stuff came out on Wall Street, not in medical journals. And this is a really big deal because IBM has Watson, and IBM bought this company, Merge Healthcare, which has one of the largest repositories of CT scans, MRIs, all this digitized imaging, right? So you think about today, where somebody take a picture of me right now. I'm not a big Facebook guy, so actually this won't work. But people who are really big in Facebook, who have this facial recognition software, right? So if you can recognize someone's face anywhere around the world, you know exactly who it is. It's not difficult to cross over on the medical side to say, okay, well, how can we recognize, that's pattern recognition, right? So how can we recognize imaging that says, okay, these certain characteristics of this image are related to this disease, so artery stenosis or this type of tumor, so certain findings, right? So it's all pattern recognition. So that's exactly what they started doing. And they're using IBM, and there's other organizations we'll talk about that are using this to make diagnosis and to make management decisions for certain diseases. And that's when we get into this artificial intelligence versus machine learning comparison. And this is just going to be a brief definition, just so you can be aware of what the differences are. Most of the stuff, I think, all goes goes back to Terminator or Blade Runner, and who knows if this so some people say the Matrix was a documentary. I don't know if that's true or not, but I'm a big conspiracy theory guy, so and other people think that we live in the Matrix right now. I mean, like this is a virtual reality. So there's a theory that actually someone's playing us somewhere else, and we're just moving for someone. But anyways, so artificial intelligence, you can see the trend was really big, and then died off, and now it's picking up again. And I was trying to look back to see if there was like a movie. Maybe this is a Will Smith movie, artificial intelligence. Not sure. So to get an idea of what artificial intelligence is, I'll tell you a story about this man. So this man, this is a story of a father and son. And the father, I don't remember his name, but the dad was in his late 80s, and he was diagnosed with some type of lung cancer. And his son wanted a way to continue to visit with his dad because he really loved his dad, and so he sat down and interviewed his dad for 12, 14 hours, or at least the equivalent to 12 to 14 hours, 20 hours, got all of these conversations and had it transcribed. So all the conversation was transcribed. Then he took all that transcription and coded it, and put it into formulaic questions to say, okay, when I ask this, this is the answer. And when I ask this, this is the answer. And then he put up certain parameters to say, okay, so building it in a way that within the parameters that if he asks a question, that it can draw from a number of different places to answer a question. So essentially, he was doing artificial intelligence, so a knowledge base and a query system to solicit answers. So you see the son saying, hey, Dad, did you know that Mom buried marijuana in the backyard? And the dad answers, oh man, that's crazy. She does crazy stuff all the time like that. And so all these answers, and so he has a conversation with his dad whenever he wants. So that is artificial intelligence, and so there's parameters that are set. And so machine learning is a little bit different in that you give machines access to data and let them learn for themselves so that they can make inferences and make decisions, not necessarily within those parameters, but they can start learning to say, oh, okay, this happens. Well, this is, if you give characteristics of is this a bear? So I guess like 10 years ago, computers weren't able to answer what a cat is. But now they have all this data to pull from, and they can say, okay, this is a certain height with fur, and it walks this way, this is probably a cat. And then if they put the same data to say there's something tall and it's roaring, makes loud sounds, and oh, this is a bear. But now the machine would say, now it's time to run, because it learns that that's not a safe environment to be in. Right? So that would be machine learning. So there are organizations now, big companies, like I said, these disrupting healthcare, right? IBM and other companies that are partnering with smaller tech startup companies that then partner with bigger institutions, most of them academic institutions, and figuring out ways to provide healthcare in a way that's cost-effective, cheap, and very futuristic. And so one of them is, let's see, Sinatra. One of these groups here, they're doing artery stenosis studies. So what they're doing is they're going back and looking at all their patients in their system that had CT scans, and they're just letting artificial intelligence and machine learning pick up all the patients that had arterial stenosis, so carotid artery arterial stenosis, and they say, okay, this is this patient, and let's move them. The program already figured out, they did a risk stratification, or they did machine learning on these scans, and were able to pick out those patients. They're doing the same thing with certain lung findings, and they're drawing in data from whatever the patient's demographic information is and all the times they've visited the hospital, and then they're making inferences to say, oh, this patient probably has this type of lung cancer, or this is the finding suggestive of. All that without a physician. They're just running the data. So radiology, I think if I had to pick one, that would be the last job that I would take in the future. All right, so Terminator. Okay, so this is the next thing is augmented reality. So you remember when I don't know if you remember this. Everybody remember Terminator? Yes. So he walks into places, right, and he starts getting all this data from things that he would look at. This is a target, this is safe, and start building up all this other extra information. So it's reality, but it's augmented with additional information. So it's augmented reality. And people are doing this now, right? This is the big one, Pokemon Go. Does anyone play Pokemon Go? Yeah. Okay, it's a little strange, but anyway, so this reality, and then it augments it with certain interactive features. And so is this being used in medicine now? Yeah, there's a few companies doing it, and this is one example of it. So AED devices, you put the phone up and you can see where those devices are located in the city that you're in. So in case you have some kind of emergency, you look around, and it maps it out for you. I'm gonna play these videos here for you, so you can see. I don't think. Oops. I didn't link it up. Let's do this one. Are we allowed to stream YouTube or no?
Try it and see.
I forgot about it. I didn't think about that. Yeah. Okay, guess not, huh? Oh, yeah, okay. So he just took out her tumor. You didn't realize it. No, I'm just kidding. But you could see. I'm going to show you one more. And I'll just skip this here. So these are using patients' own imaging, right? Skip a little bit.
Hey CNBC fans, thanks for checking out our YouTube channel. Here you're going to find videos packed with
That's
all of the
something else.
information that you need to be smarter about your finances. You can subscribe by
Hear that?
clicking right here.
Oh, this is not what I don't,
Or the I right here to watch the latest from CNBC. Thanks for watching.
okay. I don't know what that was about. So that, what the,
Today,
uh-oh.
I am honored to have Pamela Davis
What the heck? Another,
of Case Western Reserve University School of Medicine.
where is
and
that?
two of her team members, Henry and Jeff,
How do I turn this off?
join us to tell us more about teaching medicine with HoloLens. Welcome.
Internet Explorer?
Davis. Thank you for joining us on stage.
Oh, there he goes, thanks. Oh, man. That almost got scary, right? It was like, oh, my career. All right. So you saw that that was actually the patient's real anatomy, and so they sent the images to the goggles that the physician's wearing, and then so you can do the surgery with that patient's anatomy mapped out for you. So I'm going back to this sports thing. So I really love basketball. I love sports, and so Golden State Warriors. They're really I think they're gonna be dominant for many, many years. Sorry, Spurs fans, but what they're doing is they're using a lot of startup culture within the organization to run it a lot more efficiently. They're doing a lot of analytics on their players, and they're using different ways to disrupt. And mostly, this is like from a fan standpoint and from a owner standpoint that you're seeing this, but this kind of startup culture is permeating through all parts of our lives. So there's the Dollar Shave Club, there's Uber, so that was my company actually, and there's all these things that are happening that are really futuristic, but it's happening now. And so you see this Amazon Prime Air, right? So there's drones that are gonna be delivering packages to your door. It's crazy, and so I think that as a medical culture, that if we already do this now, but if we move it forward to do it in other projects, right? So like the whole idea of coming up with something, building it, testing it out, but doing it in a way that's quick. And I think that one of the things that we have that is good and bad in medicine is that there is a long time to adapt to new technology or new ideas. I read a paper, at least it came out in the mid-90s, that looked to see how the average time that the medical field adapts to new findings. And it's like an average of 10 years. So it's a little slow, but I think people, if we don't adapt as an organization or as a field, that people are going to adapt, do it faster than us. They're going to do it for us. And so I'm talking about those tech companies, and then we should be the ones kind of leading that charge. So there's this whole thing of disruption. What could we do to really change the game for patients? I talked about the whole fringe thing, where patients want to move to a place where they can diagnose themselves and treat themselves. That's not uncommon, right? Patients sometimes have patients that come in and be like, I want the works, or at least when I was in med school, give me the works, and whatever that is. They want like a battery of tests, but that's kind of the culture where we're moving to, where it's like, I want to know what my microbiome looks like. Yeah, I don't, but some people do, and so could we provide that for them? I don't know. We can. So the other mantra is fail fast. So do it early. Fail fast, fail early. That way you're not going to be wasting all these years to know, like, oh man, this is probably a bad idea. That's a whole medicine, right? The drug trial from 12 years and $360 million. That's not really Silicon Valley, right? That's expensive and a long time. And then be lean. So don't get a lot of extra things that you don't need. Just figure out the problem and do it as fast as you can in a way that's really efficient. And this is being done now by your organization, by Dr. Patel. So eventually, he'll be delivered via Amazon drone. But so you have started this, and there's Bob there, Santa Bob. So what he's doing is flying out to El Paso every certain amount of weeks to do procedures on patients that wouldn't have gotten these procedures, right? So they would have to fly out here. And this whole thing of let's deliver the services to patients and not the other way around. I think it's a little patriarchal. It's a little, old school to be like, hey, you guys got to come see me because I'm the star of the show. And it's not like that anymore. Everything's getting delivered to people's homes. So why not do the same thing with medicine? Why not deliver Dr. Patel to all the homes around around El Paso? And so I think this is a really neat example of how your organization is being it's disruptive in the field. I think that was unheard of. So that's the end of my talk. I hope you enjoyed the talk. There it is. I'd like to thank everybody involved, and thanks for inviting me. It was really a great honor for me to be here, and I apologize for being late. But seriously, it is a really great honor for me to be here and talk to you. And thank you for lending me some of your time. So any questions? No? Yeah.
We have patients in El Paso, and one thing that I wonder about, when you mentioned when you left for school, you weren't as familiar with the internet then. Do you feel like technology has